Aku mengasuh rasa, mendengarkan jiwaku berkata-kata. Tak mungkin aku abaikan kata hati. Ku harus jujur pada hatiku. Kau dan aku tak bisa bersama, bagai syair lagu tak berirama. Selamat tinggal kenangan denganmu. Ku melepaskan kau pergi. Kau dan aku tak bisa bersama, bagai syair lagu tak berirama. Selamat tinggal kenangan denganmu. Senyumku melepaskan kau pergi. Kau aku tak bisa bersama, bagai syair lagu tak berirama. Selamat tinggal kenangan denganku. Senyumku melepaskan kau pergi. Terakhir ku katakan padamu, jangan tangisi perpisahan ini. Kau harus kuat melepasku pergi dari hidupmu. Bila kau kan mengerti mengapa semua ini harus terjadi. Memang tak sejalan dengan yang kau inginkan dan yang kau mau. Cinta ini selalu untukmu. Rasaku takkan mungkin pernah habis meski kita tak lagi bersama. Jiwaku tetap utuh untukmu. Kelak kau kan mengerti mengapa semua ini harus terjadi. Memang tak sejalan dengan yang kau inginkan dan yang ku mau. Cinta ini selalu untukmu. Rasaku takkan pernah habis meski kita tak lagi bersama. Jiwaku tetap rasaku takkan mungkin pernah habis. Tak lagi bersama, tetap waktu tetap butuh untukmu. Sempat ku mengerti
Mana on kamera ya, Mak? Biar
saat ku tersesat, beri cahaya saat ku sendiri dalam gelap. Namun waktu tak pernah rela, akhirnya kau pun pergi. Lambat ku sadari kau teramat berarti. Terlambat untuk kembali dan untuk menanti kesempatan kedua yang takkan mungkin pernah ada. Ku kau hembuskan angin saat ku bernafas, siramkan air saat aku dalam kekeringan. Namun tak pernah ku hiraukan semuanya. Tiada lambat ku sadari kau teramat berarti. Terlambat untuk kembali dan untuk menanti kesempatan kedua yang takkan mungkin pernah ada. Biarkan ku hidup dalam penyesalan ini sampai nanti kau akan kembali. Terlambat ku sadari kau teramat berarti. Terlambat untuk kembali dan untuk menanti kesempatan kedua yang takkan mungkin pernah ada. Terlambat ku sadari kau teramat berarti. Terlambat untuk kembali dan untuk menanti kesempatan kedua yang takkan mungkin pernah ada. Yang takkan mungkin pernah ada. Di atas peri kau menari, di atas tangis kau bernyanyi, kau sayat hatiku dengan cintamu. Cinta bukan hanya harapan, cinta tapi kepastian. Cinta bukan menyakiti hati. Di saat luka kau tak ada, di saat
Makin aktif si kecil, kulitnya perlu perlindungan ekstra. Pakai Johnson's Milk Plus Rice Baby Lotion.
duka kau tak setia, cinta seharusnya tak begitu. Cinta bukan hanya harapan, cinta tapi kepastian. Cinta bukan menyakiti hati. Bukan hanya cinta. Cinta tapi cinta bukan menyakiti hati. Saat bukan kau begitu. Lagu cinta
Pertama, perjumpaan tak sengaja menyimpan ruang rindu saat senja. Ku tak ingin seperti lagu-lagu cinta, hanya indah dalam permainan kata. Kepada yang tercinta dan hanya untukmu cinta, sampai kapan menunggu cinta? Ku yakin kau yang paling nyata, hanya kau yang di hati. Meski lamban peduli, jasmaniku teguh menanti sampai restu berpihak pada semua rasa ini, wajahmu menghangatkan rasa dingin. Denganmu tak pernah ku rasa jadi rumit. Bahagia sehingga terlukis di langit. Kepada yang tercinta dan hanya untukmu cinta. Sampai kapan menunggu cinta? Ku yakin kau yang paling nyata, kau yang di hati. Meski waktu lamban peduli, jasmaniku teguh menanti sampai restu berpihak kepadamu. Pihak padaku. Jangannya untuk cinta sampai kapan cinta. Ku yakin meski waktu lamban peduli, jasmaniku teguh dan restu pun berpihak. Restu pun berpihak padaku.
Cek. Oke, selamat siang semuanya. Om Swastiastu. Assalamualaikum warahmatullahi wabarakatuh. Shalom, nama budaya, salam sejahtera untuk kita semua. Jadi terima kasih atas kehadirannya adik-adik, mungkin ada rekan-rekan dosen dan juga rekan-rekan tim peneliti yang hadir pada siang hari ini. Apakah perlu kenalan? Perkenalkan, saya Dr. Aiswan Dewi sebagai koordinator program studi sarjana kesehatan masyarakat dengan dukungan dari senior saya, Dr. Sawitri yang memerintahkan untuk berdiri di sini. Beliau koordinator program studi magister ilmu kesehatan masyarakat. Jadi kegiatan guest lecture atau kuliah tamu hari ini diselenggarakan kerjasama dari program studi S2 dan S1. Siang hari ini kita dapat dengan berbangga karena kehadiran dua orang pembicara tamu, Dr. Matthew Kelly dari Australian National University dan Dr. Miss Rachel Merrick dari Field Epidemiology Training Program Fellow di Wales, United Kingdom. Jadi satunya dari Australia, satunya dari Inggris ya. Jadi dari dua kutub yang berbeda, tapi nanti kita bisa mendengarkan. So it is our pleasure to have you here, Matt. This is I think third time maybe you will bring. So it's really delightful and happy to have you here to share your research, your experience. So Dr. Matthew Kelly adalah senior research fellow di Australia National University. I think he has different range of research from verbal autopsy and also TB, diabetes, and also related to climate change. So we will be listening to his lecture today, and please feel free adik-adik teman-teman kalau mau bertanya nanti ada kesempatan untuk bertanya. Kemudian jadi the guest lecture today will be we will be arranged like this. First Dr. Matthew will talk first and then followed by Rachel. Nanti adik-adik silakan kalau ada pertanyaan ditulis dulu. Kalau mau disampaikan dalam bahasa Indonesia juga silakan ya. Nanti kalau mau dalam bahasa Inggris sambil latihan juga silakan ya. Oke, jadi pada sore hari ini juga hadir Bapak Wakil Dekan Kemahasiswaan dan Informasi yang akan menyampaikan sambutan pembukaan gitu ya untuk memulai dari kegiatan guest lecture kita pada sore ini. Pada Prof. Adi, waktu dan tempat.
Thank you, Dr. Ayu. From me, probably only 5 minutes. Usually, opening in Indonesian setting is quite long. Sometimes we have welcoming dances and prayers and so forth. But today we are very fortunate that we met Dr. Matthew Kelly and Miss Rachel to give lecture to our students. Thank you very much. And on behalf of the Dean of Faculty of Medicine, my name is Adi. I am the Vice Dean for Student Information and Cooperation Affairs. The Dean currently has another meeting at our hospital, at the Sangla Prof. Ngurah Hospital, our main teaching hospital. So he asked me to greet and welcome you here. So we are very happy and thank you so much for coming to our institution again. I think I met you so many times already, but this is first time for Rachel. Thank you for Dr. Ayu at the School of Public Health, and the convener for the undergraduate program, and our senior Dr. Savitri, convener for the master program. We have also Dr. Sutarsa, Dr. Dwi, Pak Ari, and all the faculty members, and especially our students, the Master of Public Health and Bachelor of Public Health students. Thank you very much for coming today. And we really hope that today's session, today's lecture will give them a lot of insights, a lot of ideas, and a lot of probably research ideas maybe for their final assignment or final research projects. Okay, maybe that's from me. Thank you once again. And I conclude with Balinis Paramo Santi. Om Santi, Santi Santi Om. Thank you very much.
Yeah, thank you, Prof. Adi. So I think we cut the opening short ya, sehingga kita bisa lebih banyak berdiskusi. Not like the usual one that we have long and with the a lot of different opening session. So the guest lecture today will be moderated by our Dr. Nyoman Sutarsa. Ada yang belum tahu Dr. Sutarsa? Belum ya. Jadi Dr. Sutarsa adalah salah satu dosen pengajar di Departemen Kesehatan Masyarakat dan Kedokteran Pencegahan, tapi beliau juga adalah senior lecturer di Australia National University. Jadi sangat berbangga Dr. Sutarsa bisa selalu membawa banyak peluang buat teman-teman, termasuk juga buat adik-adik di sini ya. Jadi nanti bisa belajar dari Dr. Sutarsa dan juga dari para pembicara. Nah, nanti untuk masalah materi dan juga yang disampaikan oleh masing-masing pembicara nanti akan disampaikan langsung oleh Dr. Sutarsa juga ya selaku moderator. Silakan Dr. Sutarsa. Di depan ya.
Selamat siang, good afternoon. So very happy to be able to moderate this session. So today we are very honored to have two very prominent academics, so one from Australia and one from the UK. So without further ado, I just would like to introduce again our guest lecturer. So the first one is Dr. Matthew Kelly. So Matthew Kelly is a senior research fellow and also on global health in particular, but also a convener for the Master of Public Health program at the Australian National University. And Matthew has lots of research interests, but primarily on public health, nutrition, and also tropical disease. So Matthew will be talking about the emerging of tuberculosis and diabetes mellitus in Indonesia. So I think it's really important topics. So it's a lot of potential research topic from Matthew's presentation today. So Matt, so I'm handing it over to you.
Testing. Okay. Hello, everybody. Selamat siang. Thank you very much for coming along to my talk today. I'll just make sure my slides are there first. So yes, I'm very happy facing with large parts of the population having TB and diabetes. And we'll finish with what to do next about Is that supposed to be the highlight? Maybe it's gone out of battery. Thank you. Okay, so tuberculosis. we'll start with tuberculosis and then we'll move on to the comorbidity. So as you're all probably aware, tuberculosis is a bacterial infection. It's caused by a Mycobacterium tuberculosis, spread by generally by coughing, sneezing, and that sort of expelling of the infectious agent. TB has two formats or forms through the life of humans. It can be latent, which means people who are carrying the bacteria that causes tuberculosis disease but are not actually sick. And this can be, you know, a very large proportion of the population. I'm not sure of the exact figure in Indonesia, but it can be up to half of the population may have latent TB at any one time. And then later you can develop active TB where the disease actually causes symptoms and you become infective and can pass the disease on to other people. So TB is important because it's, until the COVID-19 pandemic started, it was the world's biggest infectious disease killer. And now it's the second biggest, and perhaps as COVID starts to decline in causing mortality, TB may end up being the most deadly infection again. Okay, these are the common symptoms of TB. Again, I'm sure you're all familiar with this, but coughing is the most prominent symptom, but also weakness and fatigue, weight loss being an important symptom because it then reduces the ability to fight the infection as well. For those who are untreated, who have TB and don't receive timely treatment, mortality rates can be very high. So risk factors for nutrition, for TB, sorry, are generally living in close contact with people. It's not as acute an infection in that way that a short contact will cause the disease. It's generally from living in close contact with people. Population density and people living close to each other is a risk factor for passing on the infection. And particularly living in poverty, because that often also means living in more crowded conditions. It also often means less robust nutrition status and those sorts of things as well, which make you more susceptible to the infection. But any other medical condition that weakens the immune system can also, in particular, make you more likely to move from the latent TB infection to the active TB infection if your immune system is not strong. So over many decades, we've been worried about HIV and TB infection. This has been a target of a lot of global health attention and efforts to track people who have both of these conditions, because people with HIV are much more likely to have poor treatment outcomes and to die from TB. Under nutrition as well, because it affects the immune system. But as we'll come to in the topic of this talk, chronic non-communicable diseases, which also affect the immune system, are also risk factors. And as you know, we'll move on to diabetes soon. Okay, so just briefly on the global burden of tuberculosis. When we talk about 2 billion people being infected, we mean with latent infections mostly. There's, you know, a quarter of the world's population living with a latent TB infection. But for active TB, there are 10 million new cases every year and 1.5 million deaths. And this is where we come back to it being the world's second deadliest infection, causing 1.5 million deaths. As we know, most active TB cases are in low and middle income countries, and they're particularly concentrated in these 8 countries listed here. Indonesia being in the top 3, along with India and China for numbers of tuberculosis cases. And that's why we're concentrating on Indonesia in this talk as a country with a high burden of TB, but also, as we'll come to, a country with a rising diabetes rates. So also you can see it's mostly Africa and Asia where most of the countries with high burdens are. Not sure how well you can see that from the back, but this is a global map of incidence of TB, meaning new cases per 100,000 population each year. So you can't see. Oh, you can see that one. Okay, good. So obviously you can see there's a sort of a concentration of higher incidence across the tropical countries, but particularly in South and Southeast Asia and in Southern Africa, where the most cases are. Okay, and I'm going to say these graphs are not very good on this on the next few slides, but I did not create them. They're from a TB report. So there have been many efforts to reduce the TB incidence burden globally. We'll come to some of the methods later. And there has been a gradual decline in TB over the recent decades, but not in the trajectory that we need to actually, we'll come back to the end TB targets in a moment, but we're not on the trajectory that's going to meet those targets as things stand now. And now with new threats such as the diabetes that we'll talk about, it's even more of a challenge. But we know, just see there's little uptick here for various reasons during the COVID-19 pandemic, even those advances or gains that had been made over the decades leading up to that have now been not reversed, but have now been challenged. And 2021 and 2022 actually saw much higher incidence of TB than had been in the decade leading up to the COVID pandemic. So, you know, TB is it's a complicated disease. It's hard to eliminate. It's people living in close quarters together that are passing it on to each other. But despite that, active case finding, better diagnostic methods, better treatment with drugs has led to some decreases, but these are now being challenged by COVID and by other factors. And in particular, I mean, the bottom half of that graph, we're not talking about HIV much more today, but you can see HIV and TB as a comorbidity burden has also been decreasing a lot since 2010 or so, partly because HIV treatment has become more effective. There we go. Oh, no, we went too far. Yep, there we go. This is basically saying the same story, so it doesn't matter, we could have skipped this one. This is just saying by region, the gradual decline of TB incidence by region over the last 20 years. That we can see the top left-hand corner, the African region has had quite impressive decreases. Europe, even more effective. In the Pacific, yes. In Southeast Asia, not as much, but these are WHO regions, by the way, as well. So Southeast Asia in that context includes India and Bangladesh, which are the other high burden countries. Okay, now we'll come to Indonesia. So Indonesia is the second highest burden globally. I sometimes see it's told it's the third and the second, but I think if we're talking about absolute numbers or of incidence, right? Obviously Indonesia is the world's fourth biggest country. So there's that population that means there will just be more number, but in incidence per 100,000 population as well, it's in the top 3 countries. There's a mortality rate of 52 per 100,000 population, which is not as high as other settings. Indonesia is having some effectiveness in its treatment program and its case detection in recent decades, but still a high mortality rate. But I want to look at this graph here is similar to the graphs we looked at in the previous slides, looking at the incidence trends over time. So Indonesia had reduced from, nearly 400 down to close to 300 cases per 100,000 population per year. So it was making fairly good progress, but we can see the big uptick again at the end there in 2021. Indonesia recorded more cases in 2021 than was recorded for quite some time before that. So COVID-19, as well as the diabetes, which we will get to in a second, is also causing some impact on TB incidence in Indonesia. So what is the WHO recommendations for what we should be doing about TB? Since 2015, the World Health Organization has had an end TB strategy, has ambitious targets to reduce new cases by 80% from 2015 to 2030. So we're already a fair way through that, that target period. And by 2030 to also have a 90% drop in mortality from TB, and also to protect families from healthcare costs. So, we know TB care can be expensive if it's not covered by a universal healthcare system or government support, which I believe it is in Indonesia, but it is not in all settings. So for the NTB strategy to be successful, this is the downward trajectory that would be needed in incident cases. And this is the current global trend, which is downward, but obviously not at the downward angle that we're looking for here.
Mayu? Okay, so hold your questions. So Matt will continue the presentation and then we can have a discussion afterwards.
That's where we're up. Now the two slides aren't doing the same thing. No. The two screens. And that's the important one, but that one's different. Competing with the band. Just start talking a bit louder as the band gets louder outside. It's a spoiler, they're going to my slides too soon. So, I mean, I'll let you solve the internet problem, but do you know which slide we're up to? It's still a few back from that. How many people were in the online? How many people were in the online? Oh, really? So people on YouTube are saying, what's going on? Yeah. This is still not working.
Yeah, this one.
That one. Inina.
Yeah. Sorry.
Okay, we're back. So the Zoom people can see us now as well. Now I'm getting some feedback. Oh, okay. All right. Let's keep going. Okay, so we were talking about the WHO NTB strategy, and here we have what's going on in that area in Indonesia. Indonesia's latest protocol presidential decree was in 2021, which prioritized active case finding, TB medicine availability and prevention approaches. and there's some details there, but obviously in the Indonesian health system, with a decentralized health system, many of the activities will be the district level governments will be responsible for. So the presidential decree gave measures to strengthen district and city level prevention and control and treatment programs. There we go. Okay, so that's TB. That's TB control. Now we're going to switch gears a bit. Okay, the epidemiological transition is obviously something I hope you would have learned a bit about, maybe in your master's programs already. But over the last half century or so, most countries in Southeast Asia's disease burdens have started to shift from infectious disease and child and maternal health problems as the major health problems towards having non-communicable diseases as the major health burden. To some extent, this is because of population aging. So childhoods become healthier, immunization programs, sanitation, hygiene. People live through childhood, then they'll live into older age, and then older age is obviously associated with more chronic diseases. So that's one driver, but also dangers. So now, you know, we see chronic non-communicable diseases, particularly diabetes in younger people. It's not just of elderly people. So this is the major health change over recent decades in Indonesia. So this is a very strange graph, but the blue square here is the proportion of deaths that are happening from non-communicable diseases, and the orange section is the deaths from infectious diseases and child and maternal mortality, and then the green section is the proportion from injuries, and the whole box is all deaths in the country in a particular year. So it's a very basic graph, but just to see, the blue box has got bigger. Okay, so from only 30 or so years ago, around half of deaths were from non-communicable diseases. Now it's nearly 80% of deaths from non-communicable diseases in Indonesia. So not over a long period of time, this has happened fairly quickly. Okay, so and the most important of those NCDs in the Indonesian context are stroke and heart disease. The leading cause of death in Indonesia is stroke. But diabetes is in the top 10 causes of death as well. Okay, so although we can say that 78% of deaths are caused by non-communicable diseases now, we still have a substantial infectious disease burden. Particularly in tuberculosis, as we've been looking at already. And this is a big challenge just in general for the health system. Before we get to comorbidity issues, obviously having a health system that's being adapted to maternal and child health problems and infectious disease control, then the health system, the health workers, the nurses, doctors have to shift gear and learn about non-communicable disease, screening, control and treatment. And as we'll get to, the two burdens do exacerbate each other or make each other worse, as well as what we'll come to in a moment. Having undernutrition and having infections does make you more susceptible to non-communicable diseases as well. Okay, so now on to the actual topic of my talk, which is diabetes and tuberculosis. So as you probably know, diabetes is a chronic disease that has a big impact on the immune system. So that part of the impact of that immunity challenge is that when 30 to 40 to 50% of your population have latent tuberculosis, and then they incur an illness that reduces their immune system function, then you're much more likely to move from latent tuberculosis to active tuberculosis. You also, when being treated for active tuberculosis, you're much less likely to have a successful treatment outcome. And that's one of the major challenges with the diabetes-TB comorbidity, is that people are more likely to get sick and then are less likely to have a successful treatment outcome. So we'd like to pose the hypothesis that diabetes will be a threat to the NTB strategy, even after the COVID pandemic passes to some extent. We're still going to be challenged by diabetes as a factor that's increasing risk of TB. And ultimately, diabetes also increases the risk of mortality from TB. So, okay, I know this, you can't actually see this graph, but I'll tell you what it is. So when we have treatment failure and people are still having illness at the end of the treatment program because they have diabetes comorbidity, they're more likely to develop drug-resistant TB and more likely to have TB relapse, and it will be drug-resistant TB. This is just a systematic review that I found that looked at the odds ratios of having drug-resistant TB if you were also positive for diabetes. And you can see across all these studies, there's a range from 1.9 to 5.3 odds ratios, assuming everyone's familiar with odds ratios. So, we can see clearly that as well as being more likely to get sick from TB, you're more likely to have drug-resistant TB as well. And that's the biggest threat to the TB strategy. So that's the major problem with diabetes. So, we saw those graphs before about the overall disease in Indonesia and the growth of non-communicable diseases. But I think diabetes is probably the disease that's growing most rapidly in Indonesia right now. We've had a doubling in prevalence in the last 20 years. And the biggest challenge, I guess, in a transitional setting like Indonesia is that screening processes are not adequate. I have seen some studies where they have gone into communities in Indonesia and tested people for diabetes, and only around half of the diabetics knew they were. And even those who know they are often don't have the diabetes under control. So this is a major challenge. Okay, so we've been looking at the 2018 Risk-Estas data. I assume everyone's familiar with Risk-Estas. It's the National Health Survey that's done every 5 years. And we looked at people who had self-reported having TB and self-reported having diabetes in that study. So we're not screening them, we're not testing them for diabetes. But the unit of analysis here is district, so kabupaten. And the ones in red are places where 20% or more of people who self-reported having TB also had diabetes. So, if the Risk-Estas data was saying around 6 to 8% of adults have diabetes, but here we're finding, and if you have TB, you're 20% of you have diabetes, then that's a clear picture of the burden, but also that how closely the two diseases are working together. Now, I'm planning a study of this disease burden, and I'd like to work in Bali and South Sulawesi. That's why they're circled on the map. We can see in particularly in Buleleng district in northern Bali is one of the red districts there where the burden of both is high. And that was 2018 Risk-Estas. I know we're having a new round any day now will be released. And I imagine we will see that diabetes has grown even more since 2018, but yeah, we don't know. So coming towards the end of my talk now, just a quick summary about the situation in Indonesia. It's a high burden country for TB with rapidly rising rates of diabetes. The World Diabetes Federation places Indonesia as one of the countries in the world at most risk from diabetes increase over the next decade. And worryingly, there are very high levels of undiagnosed diabetes, which is further going to challenge that. So, you know, if people are diagnosed with TB, but they don't know they have diabetes as well, that's going to be even more of a challenge. You know, therefore, you know, this should be a big priority for the Indonesian health system. So this is sort of presenting the same figures as I just showed in that map, but there have been some sort of epidemiological studies that have specifically screened TB patients for diabetes, and most of them have found 12% to 20% prevalence of diabetes in TB patients. So the World Health Organization does have a framework for what to do about this problem. There is a framework for the management of comorbid patients. And the main recommendation is, in a high burden setting, you do bidirectional screening. That means a new TB patient gets diagnosed, you screen them for diabetes. If a person gets diagnosed with diabetes, then you should screen them for TB as well. And obviously, if you do diagnose those people, then you also need to offer them referral for treatment for both conditions. And I think this one's particularly important as well, that, you know, in a lot of settings with many aged people, elderly care settings and those sorts of things, where there's a lot of people with diabetes, then we need to also consider infection control for TB to reduce TB transmission. There has been one review recently of what the situation is regarding TB and diabetes care management and care programs in Indonesia. We know that since 2016, the Indonesian Ministry of Health has had bidirectional screening as a priority, and it has been something that is, I would say, is supposed to be happening in Indonesia. It is in the policy, and the National TB Control Program does recognise the challenge of diabetes. As I understand now, and I'm happy for any of my Indonesian colleagues to provide more detail, but as I understand, the main focus now is particularly in aged care settings, screening diabetes patients for TB. But there's been very little assessment or, you know, assessment of the effectiveness or how much this is actually happening with the decentralized health system. You know, there will be some districts that are active in this area and some that aren't. And so we're not sure exactly what is going on at the moment nationally, but that is the policy. I might just keep moving through this because I know we've slowed down a bit now, but so, you know, the challenges, there's a lot of challenges to implementing a co-morbidity control program where we're looking at infectious diseases and non-communicable diseases. Obviously in the Indonesian health system, they're, you know, governed by different areas of the Ministry of Health, the separate health information systems, though I know we're moving towards the Satu Sehat sort of system of having all health information systems integrated more effectively, but we're also not quite there yet. Or you're not quite there yet, I should say. I'm not Indonesian yet. And, you know, as we said before, with health staff that are familiar with one area of disease might not be familiar with the other and won't be familiar with comorbidity management as well. A lot of TB in Indonesia is also diagnosed through the private health system, and we don't also know to what extent that system is looking at the comorbidity challenges as well. And finally, particularly in rural areas, diabetes screening rates are very low. So I'm proposing these points here as next steps in investigating what the situation is in Indonesia with TB-DM comorbidity. You know, we have all these cohort studies that have been done in different settings that look at the treatment outcomes, and we, you know, fairly sure around what the you know, the actual impact of, in terms of odds ratios and things, is of treatment outcomes for DM patients. But, you know, in every setting needs its own evidence, and we need more local evidence in Indonesia of what the particular situation is here. This will also give us a better picture of the actual comorbidity burden. And then we need to investigate the most effective ways to implement and assess those WHO recommendations in terms of bidirectional screening, referral pathways, and so on. You know, and we also need to understand exactly what is going on currently with screening programs across the country. And again, to understand the private health sector's role in comorbidity management. So I'm currently trying to develop some research in these areas in Indonesia, so I hope we'll have more evidence soon. And that brings me to the end of my talk. So it went a bit longer with all the interruptions and the music and things, but thank you for listening. I'm happy to answer any questions after Rachel gives her talk.
So thank you, Matt. So Matthew, yeah, so we will have a discussion towards the end. So we will go or move to the next speaker. So I think Matthew summarized the key points towards the end of his presentation. So it's actually make my job a lot easier. So, but there is a lot of opportunity for future research in this space, and even for our master's student, also the Bachelor of Public Health students, even looking at preparedness in primary care, for example, for conducting dual screening, or looking at, for example, how ready the community health center to report the comorbidity, for example. That's something that's doable at this level. So that will provide more evidence into this particular topic. Thank you, Matt. It's a really comprehensive elaboration, and yeah, and then you are presenting to Indonesian audience, and then you actually know a lot more compared to us, and thank you for the knowledge. And the second speaker, I would like to introduce Rachel Merrick. Hopefully I pronounced your name correctly. So Rachel is a fellow at the United Kingdom Field Epidemiology Training Program, and she completed the program already. And she has been involved in 6-week international deployment with the WHO to provide epidemiological support for a national outbreak of cholera in Kenya. So it's not in the UK. And she also worked previously as a senior scientist at the London for Public Health, England. And she mainly working on blood safety, hepatitis, STIs, HIV, but also supported the national COVID-19 epidemiology cell during the pandemic. So she has a lot of experience on the ground. So today in particular, she will be talking about nosocomial COVID-19 in the UK. So over to you, Rachel.
Thank you, Sue. And hi, everyone. Pleasure to meet you all. So I'm Rachel, and yeah, very excited to be here today speaking with you all. It's my first time in Bali, so if you've got any recommendations about where to visit, I'd be super keen to hear from you. And yeah, thanks to Dr. Sawitri for inviting me to speak today, and another of my colleagues back in the UK, Dr. Noel Crane as well, who helped arrange this presentation today. So I thought I'd tell you a little bit about myself first, just to give you a bit of context, and then I'll move on to the presentation. So as Sue said, I am a previous Field Epidemiology Training Programme Fellow, or FETP, and now epidemiologist working in Public Health Wales. So Wales is a country based in the United Kingdom. It's got a smaller population size than Bali, so about 3 million people live there. So quite tiny. And yes, on the FETP, if you're not familiar with it, it's basically a 2-year training program that allows public health professionals like yourself to upskill in field epidemiology. So Indonesia has a FETP, if you're aware, and Sawitri did that herself about 10 years ago, I believe. And the core components of the FETP are surveillance, outbreak investigation, research, teaching and communication, and statistical analysis. So I did my 2-year training in Wales, as I say, in the UK. But if it's something that you're interested, as I say, Indonesia has an FETP, and as public health professionals, if you've got a real interest in epidemiology, I would strongly suggest you take a look at that training opportunity. I really enjoyed my time on the training. So I'm going to talk to you today for about half an hour, and then we'll have some time for discussion about one of the projects I conducted while doing my FETP. So I'll move on to the next slide. I'll just get the remain. Thank you. Thank you. Thank you. I think so. Let's try that one. Next slide. Is that okay? Thank you. Thank you. So just to start to say that this work was funded. Oh, I don't think we've moved on this one yet. Hey, thank you. This work was funded by the UK Health Security Agency, which is the main public health body in the UK, and Public Health Wales as well, and I have no conflicts of interest. Next slide, please. Okay, so I want you to imagine that we are in a busy hospital ward. There are streams of people moving through the ward, be them staff or patients or the guests, and there are machines beeping everywhere. And we have lots of people occupying beds in many different spaces in the ward. And this might be one of the sites that you would see in a UK hospital. Now, early in the pandemic, we had an idea about the risk factors for COVID in patients. So we knew that people who were elderly, people who had comorbidities, and those who were male were potentially more likely to get the infection. But what we didn't know was how the environment in the hospital, things like the number of beds, the ventilation in the ward, and the number of toilets, so the built environment, how that might contribute to the outbreaks of COVID. As epidemiologists, we started to hear that there were large outbreaks of COVID on our wards, and we wanted to understand why it was that these outbreaks were occurring, what we could change in the hospital environment and prevent further outbreaks in the future. So that's where we got involved in this study. So next slide, please. The aim of our study, the one that I conducted for my FETP, was to identify modifiable hospital ward level risk factors of large COVID outbreaks to inform action. And I've highlighted inform action because as epidemiologists, we're always told that the information we generate needs to enforce change. There's no point making information that then isn't acted upon. So we were hoping to be able to give back information to our hospital stakeholders, the clinicians, the doctors, the nurses, some advice about what they might be able to change in the environment to prevent further COVID outbreaks on the wards. So next slide, please. In order to address this aim for this presentation, I will answer 3 key questions. Firstly, how did we conduct our study? Secondly, next slide, please. What did we find? And thirdly, next slide, please, what are we doing about it, or what have we done to date? Next slide, please. I'm going to break from convention and I'll talk to the second point first. What did we find? So if you have to leave now, you'll have the main take-home message straight away. So next slide, please. Spoiler, we found, next slide, that the main risk factor for large COVID outbreaks in our hospital wards, next slide, was internally transferring patients between the wards. So in other words, it seems quite obvious, when you move patients between the different wards in the same hospital, the risk of a large COVID outbreak increased. And I'll go on to explain the methods behind that now. So next slide, please. How did we conduct our study? Next slide. Next slide. Thank you. So when I got involved in this study, my supervisor, Noel Crane, who I said before worked here in Bali about 10 years ago and knows Sawitri and has really fond memories of working here, which hence why I'm here today, had started to develop a conceptual framework for how the risks in the hospital might be contributing to COVID outbreaks. On screen, you can see a direct acyclic graph, or DAG for short, and it basically shows you how factors might be related to one another. In the center of the screen in blue, we have the outcome of a ward outbreak. And then around the periphery, we have all these other risk factors that we thought might be related. And we thought this on the basis of a literature search and also just from people's expert opinion about working in hospital settings and how these might contribute. So around the periphery, we'll take an example of ward occupancy in green. And you can understand how if a ward is busier, the likelihood of a large COVID outbreak would increase purely because there's more contacts and higher risk of transmission. But you also can understand how occupancy might be related to isolation capacity. Because even if we've got a really busy hospital ward, if there's actually quite a lot of capacity to isolate people from one another, then the high occupancy becomes less of a risk factor. So basically, this DAG is a nice way of conceptualizing all of the things we wanted to consider in our study. And I'd encourage you, if you're running a similar study or want to think about visualizing how things might be related to one another, that you draw a DAG. It's quite a nice early stage in your conceptualization process for any study. And I've included the link on the bottom right of the screen, dagt.net, and that's where you can create DAGs for free if you're interested. So that was the start and the formation of our study. So next slide, please. So to summarize, we decided to run a retrospective case control study using data from the UK between April 2020 to April 2022. Next slide, please. So I'll deep dive into the kind of choice of study design a bit more. I know we have many epidemiologists in the room, public health students, but I think we also potentially have other students from midwifery, nursing, and so on. So we'll kind of deep dive on the epi a bit, just to explain a bit more about what this study design is. So next slide, please. We chose a case control study because they're good for when you've got a known outcome. In this instance, we knew that our outcome was going to be an outbreak of COVID on our wards, and we wanted to know what were the risk factors. So a case control study allows you to have one outcome and look at many risk factors. Next slide. We decided to match in our study design because we wanted to control for non-modifiable risk factors in the hospital environment. As I mentioned at the start of the presentation, our aim was to provide modifiable risks to hospital stakeholders so they could do something about it. It wasn't going to be helpful to go back to them at the end of the study and say the reason that they had COVID in their hospitals was because there was lots of COVID in the community. So if we matched for non-modifiable risk factors, things like vaccination trends in the community, infection rates, or potentially the variants of COVID that were circulating at the time, that would allow us to rule out those non-modifiable factors. Next slide. And finally, we did a retrospective study looking back over the previous 2 years, because this was more time efficient and more resource efficient as well, because we already had the data to hand. Next slide, please. How the study actually looked, I'll talk to that now with these few slides. So we recruited 3 hospitals in Wales, which, as I mentioned earlier, is a country based in the UK. And these were large tertiary centres that provided specialist care for over 700,000 people in the population in Wales. And we included wards from adult medical or surgical specialties. And this was to include a kind of study population that was representative of the healthcare seeking adult population. From these, next slide, we obtained a line list of all healthcare associated COVID patients in the ward. So there's international definitions about a healthcare associated COVID inpatient, and we followed those same definitions and defined an outbreak on one ward as 2 or more cases in the same ward within a rolling 14-day window. So that was the outbreak. Now, I mentioned that we ran a case control study, and our unit of analysis for this study were hospital wards. So the case wards were outbreaks of at least 10 patients, compared to relatively smaller outbreaks of a control ward that were 2 to 9 patients. And these might seem quite arbitrary cutoffs at the moment, but the reason that we chose those is something I'll go to later, but also because we wanted to understand why it was that some outbreaks escalated and had loads of patients involved with them, whereas some were introduced, but the outbreak remained small in size. So we want to know the difference. Why is it that some outbreaks go crazy and other ones remain small? Next slide. And to reiterate, this was a ward level analysis. So we compared one case ward, which was a large COVID outbreak, to 2 smaller COVID outbreaks, the control wards. And that was on a 1:2 ratio, as it said on screen there. And I mentioned earlier that we matched on the start date of the outbreak. And we took this as the index cases specimen date. And the reason we matched on time for our outbreaks was because I wanted to control for the non-modifiable risks that I mentioned earlier, things like infection rates, vaccination trends in Wales, and so on. Next slide, please. In order to run the study, we obviously needed a lot of data, some of which was already available, but some of which we had to go and collect and was broadly categorized into structural, operational, and clinical data. Next slide. This looked like this. So you can see some of the variables that we collected. And this relates back to the conceptual framework, or the DAG, that I mentioned to you earlier. All of those variables on the screen, we categorize them and put them as here. So under structural conditions or risks, we looked at the hospital. We looked at the ward size, which we took as the number of beds available in each ward. We took the number of toilets available and the number of isolation cubicles. For the operational conditions, we looked at the number of day staff on shift, and we had information on registered nurses and healthcare assistants. So that was our measure for staff, night staff, number of staff absences, number of admissions to the ward. So how many people were being admitted from the community, the number of discharges as a measure of flow, the number of internal transfers, so people moving between wards, and then number of patient outliers. And just to explain outliers for those who aren't familiar, a patient outlier is someone on a ward that's not in keeping with their medical needs. So someone, say, on a cardiovascular ward who actually is needing gastrointestinal care. And the reason that someone might be an outlier is because beds aren't available. Clinical information that we collected was the age of the patients involved in the outbreak, the sex, whether or not they had dementia, because there was some evidence in the literature that people with dementia had ability to walk with purpose and not adhere to social distancing guidelines, and therefore wards with dementia patients might have a higher risk of a COVID outbreak. And then finally, ward speciality. Because as I'm sure you'll be familiar with, there are certain procedures that can be done in wards that could increase the likelihood of COVID transmission, things like aerosol generating procedures. Next slide, please. So with all those data, we took them and aggregated them for the 14 days prior to the start of each outbreak. Next slide. So if an outbreak started on this date in red, next slide, we would look at these 14 days. And the reason we looked at the 14 days was because this is the maximum incubation period for SARS-CoV-2. And it would also give us a sort of early warning signal about risks in the previous 2 weeks, how those relate to the likelihood of a COVID outbreak going forward. Next slide, please. So what did we find? Interesting stuff. So you already know our headline finding, that inpatient transfers between the wards increase the risk of a COVID outbreak, but more broadly, we identified some other stuff too. So I'll talk to that now. Next slide, please. This slide can be a bit busy, so I'll just speak to it a bit. So in the center, where it says same, I'm going to tell you about how the case and control wards were similar to one another. That isn't that interesting for this study, because if case and control wards were similar, this means those factors weren't a risk for COVID outbreaks. On the other sides of the slides where it says different, that's where the factors differed between case and control wards. And that gave us an early signal about potentially what was causing the COVID outbreaks on our wards. You can see the sample size that we were working with. So case wards, we had 35 large outbreaks in the study, and control wards, we had 70 as we matched on a 2-to-1 ratio. Next slide, please. So the participants in our outbreaks, or rather those in the outbreaks, were largely male, elderly, over the age of 80 years. Lots of them had been in hospital for several weeks at the point at which the outbreak occurred. And unfortunately, 1 in 4 of them, of the index cases involved in the outbreaks, did die during the study. A lot of the cases involved had dementia, so we couldn't really assess the effect of dementia on likelihood of a COVID outbreak occurring. And the male elderly part to the study population is just mostly reflective of the population you would see in Wales hospitals. Next slide, please. In terms of the conditions in the hospitals, so most of the wards that we were looking at had 24 beds per ward, 4 toilets and 6 isolation cubicles. Next slide, please. And in terms of the operational conditions we were working with, so there was normally 7-day staff, 3 night staff, fewer than 1 staff absences per day, less than 2 discharges, and quite rare to have a patient outlier on the ward, only 1, in the 14-day period that we were looking at before the outbreak occurred. So that's the stuff which isn't too significant for our main headline findings. Next slide. So obviously the difference between the case and the control wards, by way of how we defined them, was that there were larger outbreaks in the case wards. Next slide. The control ward outbreaks tended to have a shorter duration of about a week. So not only were we seeing in the case wards lots of people affected, but also likely lots of impact on service provision because the outbreaks went on for longer. Next slide. This doesn't mean too much, I suppose, in this context, but there were differences between the hospitals we looked at, which we hypothesized were related to the newness of the hospitals. So Hospital C was a bit of an old school hospital, whereas Hospital A had a bit more ability to separate people. Next slide. And then finally, one of the early signals that we were interested in for this study was the fact that the large outbreaks, or the case wards, had more transfers of patients between the wards. Whereas in the control wards, we funnily saw more admissions from the community going into those wards. So they paint a different picture about how patient flow in the hospitals may or may not contribute to COVID outbreaks. And I'll get onto that more a bit later. Next slide, please. So to summarize and talk to some of the main descriptive findings, small outbreaks were common in our study. Next slide. This epi curve shows you the distribution of the 170 outbreaks that occurred over our 2-year study period. So on the x-axis, we have the outbreak start date. On the y-axis, we have the number of outbreaks. And then the different shades of blue are the different hospital sites that were involved. We've got a vertical line that's dotted, showing you when community testing for COVID began in Wales. And then the second vertical line tells you when the vaccination campaign was rolled out, just so you have some context to the data that we're looking at there. Next slide, please. The median size of the outbreaks we looked at was 5 patients, and the interquartile range was 2 to 9. Next slide. These peaked in terms of the number of outbreaks in January 2022, which was interesting because that was around the time that the Omicron variant of COVID was detected in the UK, and as I'm sure you're familiar with, had increased transmissibility. And the median duration of the outbreaks was 9 days, ranging from 5 to 16. Next slide, please. And when I add a line on the epi curve in pink to show you the incidence of COVID in Wales at the time, you can see that a real strong mirroring in trends between what was happening in the community in the UK and what was happening in our hospitals. The difference at the start there is probably because COVID wasn't being tested for in the community. And this makes sense because the hospital population is an extension of what's going on in the community. So if we have people going into hospital with COVID, then obviously it's much more likely that an outbreak will occur. And that's why in our study design, we decided to match for that by matching the case wards to the control wards of time of onset, because we thought one of the greatest risk factors for COVID outbreaks was going to be what was going on in the community at the time. Next slide, please. And I mentioned earlier that we had these large outbreaks that we defined as outbreaks of at least 10 inpatients. And you might have thought that that 10 number was quite arbitrary. Why did we look at wards with 10 or more cases in the outbreak versus 2 to 10? And the reason was because of the distribution of outbreak size in our study. So on the left here, you can see a histogram of outbreak size, and its positive skew tells you that most of the outbreaks in our study were small in size, but we do have an upper 25%, an upper quartile, that had 10 or more patients involved in them. Next slide. So that's this 25% here. And pragmatically, that seemed like a good cutoff for our study because it gave us a decent sample size, and that 25% looked quite different to the other 75%. And we wanted to see why it was. Those outbreaks were crazy huge and these ones were quite small. Next slide. And when we plot the time of the outbreak onset of these case or large wards outbreaks on the epi curve, you can see the distribution follows a similar trend to, again, what was happening in the community at the time. Next slide, please. I'll move us on to the statistical analysis. So you might have all seen a forest plot before, but if you've not, I'll just speak to it a bit. So on the x-axis, we have the adjusted odds ratio, and that tells us the risk of a large COVID outbreak or becoming a case or a case ward. A value greater than 1 is indicative of a risk, and you can see that indicated by the dotted line. Anything above that is a risk for a COVID outbreak, and then anything below the value of 1 is protective, so not likely to lead to a COVID outbreak. On the y-axis, we have the various risk factors that we looked at, and this goes back to the DAG that I mentioned at the very start of this presentation and each of those data items we collected. So you can see the point estimates in the circle and then the confidence intervals about our point estimate on the same line. Transfers were the main risk factor for a large COVID outbreak, and that's something I've said before in this presentation and hopefully is one that will stay with you after. And everything else fell away and was not significant in multivariable analysis. Next slide, please. So you can see there that we saw a 9-fold increased odds of a large COVID outbreak when there was a period of relatively heightened number of patients moving between the wards. And the confidence interval for that estimate was very big, but even the lower bound of 2.5 is quite large, going up as high as 33-fold increased risk. So we thought this was quite strong evidence to give back to hospital stakeholders. Next slide, please. And I wanted to show you this photo because it speaks to the situation in Wales during the COVID pandemic. So one of my colleagues, who is a healthcare epidemiologist based in the hospitals, was trying to map out how the patients were moving between the wards during an outbreak in one of the hospitals she was working with. And you can see just from the kind of busy nature of the picture how often people were being moved. So it provides us with very tangible ideas about how this could then result in COVID outbreaks in our wards. The hypothesis was that we had repeat testing at the time for people who had COVID was not recommended after they had already had a negative test. So we thought that asymptomatic cases were likely unknowingly seeding further outbreaks and amplifying transmission in the wards. Hence why, when there was more transfers between wards, there was a bigger risk of a large COVID outbreak. Next slide, please. So yeah, just as I said there, likely role of asymptomatic or pre-symptomatic transmission during the transfer process. Next slide. So what are we doing about it? What's the action that's coming from this information? Next slide. We went to the hospitals involved in this study in May 2023 to feed back our findings to them and to obtain their views, because we wanted them to be very involved in the process of hearing this information and then setting recommendations about how we can reduce transmission in the future. Next slide. So we wanted to communicate some of the lessons we had learned during the study. Next slide. We thought that our study contributed to the evidence base of a role of inpatient transfers in transmitting infections in their wards. And this was interesting not only for COVID, but for other healthcare acquired infections that might be of interest. So for example, things like Klebsiella pneumoniae, Enterococcus, and so on. So this sort of method is one in which they might seek to repeat for other infections of interest to them. Next slide, please. We also thought how this study demonstrated how a quite unusual ward level analysis might be helpful for understanding transmission in what is quite a complex environment in the hospital. Next slide, please. And we thought potentially we could scale up this study to be national. This is only done, as I say, in 3 hospitals. I think the number of patients involved in the outbreak is 100, a decent sample size, but definitely scope to make it a larger study to see how other factors that we couldn't really assess might be. Next slide, please. So we gave
Kenapa mereka nggak tanya ke saya, langsung prelingnya? Kenapa Mbak? Prelim ini hangat banget ya.
There we go. Yeah, we gave a lot of information to the staff, so we wanted to give them a chance to obviously feedback and hear their views. So they told us that bed pressures will always be paramount in their setting. So if we gave them a recommendation about trying to limit patient movement, there's only so much they can do basically in the resource limited setting that they're working with. But next slide. They did tell us that there is some scope to safely minimize patient movement. Next slide. This, they said, could be done by reminding clinicians to provide a reason for transfer prior to moving. So on screen, you can see one of the forms that has to be filled in by the clinical team before moving a person between wards in the same hospital. And we were hearing anecdotal evidence that this was often not completed, and the reason for moving someone was often non-clinical, maybe more for convenience rather than one related to their care. And so the clinician said that if there was a possibility to remind people to complete this, they might reconsider the need to move someone, kind of like a nudge theory idea. And this then could help minimize patient movement safely. Next slide. So in other words, the board decided to use our information to inform action, and they're now looking at their policy and recommendations to make these, or rather making recommendations to limit the amount of patient movement in order to prevent outbreaks going into the future. So that's how our information was used for action. Next slide, please. So to summarize all of that, thank you for still listening in on a Friday afternoon. We found that inpatient transfers were a risk factor for hospital outbreaks in Wales. We think that this had an impact not only on the patients themselves, but also on the operational conditions in the wards, hence why there is a motivation to kind of rectify this in the future. And that although this is a relevant study for COVID-19, obviously COVID's decreasingly, I suppose, a public health concern, or as much of one as we move out of the pandemic phase, but that this sort of ward level analysis can be applied to other infections that are of relevance to the hospital environment, things like norovirus, C. difficile, influenza, and other. So this sort of method might be one that can be applied elsewhere, and maybe you'll apply it to one of your studies. Next slide. That just goes to say thank you very much for listening. I really appreciate your time and patience. I meant to say Terima kasih as well. And yes, thank you very much to everyone listening on screen, to Sweetri, to Sue, and everyone. Thanks very much.
Well, thank you, Rachel. So it's a very tidy presentation, I would say. So we can follow the logic from the rationale of the study and how you change the practice in the hospital. I think it's a really, really good presentation. So I would like to invite Matt and Rachel to sit here, so in the front. So we will have maybe about 20, 25 minutes for the question and answer or Q&A or discussion, so whatever you want to call it. So, but one thing that I would like to highlight from Rachel's presentation, that's actually something that we can do here. So that's a very neat, a very nested epidemiological study. So if we're interested in looking at pneumonia, for example, so how pneumonia or nosocomial pneumonia happening in one of the biggest hospital or one in the smaller hospital, for example, that's something that we can do, and potentially that for public health master students rather than the bachelor level, for example. So there is a lot that we can learn from Rachel's presentation and how we can use that methods and then try to do that in our setting in Bali. Okay, so I would like to invite students as well as the faculty members if they have any questions or comments that they would like to make. It doesn't have to be in English, so if you want to ask in Bahasa Indonesia, that's fine. So there's Dr. Ayu here, and I can also translate your question into English. Yep, we've got one question there, so yeah, you can go ahead. Yeah. Yep.
Baik, sebelumnya terima kasih atas waktunya, terima kasih juga atas presentasinya sangat luar biasa sekali. Sebelumnya izin untuk menggunakan bahasa Indonesia. Perkenalkan, nama saya Ketut Switrayantari dari Program Studi Sarjana Kesehatan Masyarakat. Di sini izin bertanya kepada Mr. Matthew terkait dengan penyebaran DM dan TB. Nah, seperti yang kita ketahui, tadi sempat dikatakan bahwa penyebaran TB di Indonesia dan kasusnya itu sebesar 345 per tahun, per orang, per 100.000 penduduk. Nah, mungkin pertanyaan dari saya, bagaimana sih caranya untuk menanggulangi peningkatan kasus dari TB maupun DM yang terjadi di Indonesia yang tiap tahunnya itu meningkat, seperti DM itu dari tahun 2000 sampai mungkin sekitaran 2045 itu di kisaran akan naik terus kasus TB, kasus DM-nya. Dan dari pemerintah sendiri juga banyak program-program yang sudah dijalankan, namun terkait kasus TB dan DM itu di Indonesia masih terbilang cukup tinggi. Nah, pertanyaan itu bagaimana sih menurut dari Matthew mengenai dengan permasalahan tersebut, dan solusi apa sih yang efektif untuk bisa menurunkan status kesehatan di Indonesia sendiri? Sekian, terima kasih.
Yep, terima kasih ya. Mungkin Matt, so I will try to summarize. So basically the question is around how to either mitigate or reduce TB or DM prevalence in Indonesia. So there are a lot of government programs already, but to control both condition, but the prevalence remains high or even increasing in the last couple of years. So do you have any ideas around the control, including effective solution for this particular situation? Yeah.
For each disease separately, basically, right? So diabetes is incredibly complex. I mean, I think a control program for diabetes is challenged by the fact that you know, human nature, I guess, is one of the biggest risk factors for diabetes, right? We all like to eat certain foods and things. So I think there's two issues though, right? I mean, we're talking about diabetes incidence and diabetes control. So I think in Indonesia, a large need is for large-scale screening programs for diabetes. Like, I think that would be a method to get people on medication and get the diabetes more controlled. If the glycemic levels are more controlled, then that could be the target there, which also then helps with the comorbidity issues, because just because you have diabetes, if it's under control, then it's going to have less impact on the tuberculosis presentation and treatment and so on. But as far as diabetes prevention itself, I mean, you know, a lot of countries are looking at food system level changes, right? You know, sugar taxes and fat taxes and controls on what foods can be sold in schools and hospitals and things like that. To be honest, I'm not exactly sure what's happening in that sort of area in Indonesia, if those sort of programs are being implemented. But again, the challenge in Indonesia sometimes is the scale, right? So in some areas that may be happening and be quite effective, but in other areas of the country not. So, you know, a national policy that's followed through at the district level throughout the country, perhaps for diet control more, you know, is what's, you know, fundamentally needed for diabetes. I mean, that's the underlying factor, but then that's very hard to control because it's individual preferences, obviously. So, but does that help to answer your question? Yeah, thank you.
Yep, thank you, Matt. So I think because we are so focused as well on behavioral determinants at this stage, I think what you're saying around commercial determinants of health is really, really critical. So that's what's happening in a lot of successful countries where they are successfully bringing down the incidence of the diabetes because they have that sugar tax and fat tax and all of that stuff, but also they have better health infrastructure in the first place. So I think we can't really ignore that component. So if we are really concerned on behavioral determinants, there is a possibility that we are going to fail. So yeah, thank you for raising that.
And health literacy as well, that people understand those diet risks throughout the community, including, you know, it's traditionally been richer people that have diabetes, you know, but it's now moving into poorer communities as well. People may not understand the risks as well. So thank you.
Do you have any comment, Rachel, or no? Okay, any other questions? I've got one, yeah, go ahead.
So good afternoon, Mr. Matt and Mrs. Rachel and doctor. So let me introduce myself. My name is Stephen. I'm a junior doctor at Udayana University. So I want to ask Matt. So as we all know, with the rise of antimicrobial resistance, how can we ensure that tuberculosis treatment remain effective in the long term? So that's all for my questions. Thank you.
Today. So do you mean so specifically for TB? I mean, again, a lot of this comes down to early diagnosis, right? And for identifying at-risk people as early as possible. The biggest driver of resistance development is either not finishing treatment programs or unsuccessful treatment programs, right? So if the TB treatment programs are successful in reducing loss to follow-up, treatment adherence, those sorts of issues, you know, that will have some impact. But I mean, as I understand, you know, new TB drugs are being developed and things as well, though that's not really the solution to keep developing new drugs and new drugs and new drugs. But you know, it may be necessary in that sort of setting. But I think identifying people with, you know, undernourished people, people with diabetes and people with other risk comorbidities, intervening early in those groups and then getting people treated as early as possible, and then having methods to reduce loss to follow-up, which can be you know, just issues like making the treatment program as easy to adhere to as possible for patients, and having no cost associated with it is also helpful, which I believe is the case in Indonesia, but not in all settings. But you know, reducing the overall burden of the disease and treating early and successfully is really the best we can do, I think. Any thoughts?
Yeah. Rachel, do you want to share some insight? Yeah, we know we're talking about TB here, but maybe you have some comments around antimicrobial resistant program in the UK or in Wales, for example.
Yeah, sure. I can speak to it a little bit. So in terms of preventing antimicrobial resistance in the UK, as Matt said, it's about kind of correctly and promptly diagnosing people, but for other organisms, it might be correctly identifying the most appropriate treatment for them. So not necessarily for TB, but for other drug-resistant infections, you might be able to do a drug resistance test before providing the treatment to the person, and that's going to improve the likelihood of treatment success. Also about antimicrobial stewardship, so kind of empowering pharmacists, GPs, any kind of prescriber about when's appropriate to give an antimicrobial and when's not. So some of it is also about education about antimicrobial use, I'd say. So that's what I'd.
The first point you made certainly applies to TB as well. Being able to test if they are drug resistant at the start of the treatment, so you don't start them on other drugs and then find out later that they're not working and then treatment failure and so on. Yeah, thanks. Sorry.
And that's also related to the capacity of the, one is the provider to be able to detect that, but also the capacity of the healthcare provider to do that. So at the moment, if we're looking at the capacity of the primary care, for example, we are not in position to be able to identify drug-resistant tuberculosis. They need to refer that. Yeah, Dr. Ayu, yeah, go ahead.
Just to add to the discussion, so actually right now, whenever like you have a suspect TB patient, they will be checking with the rapid diagnostic test when they try to also in the bacteriologist test. Well, beside this, trying to figure out whether they are positive on bacteriology on the specimen, but also trying to look at the resistancy to one of the mainly, I think, rifampicin. Rifampicin, I think that's the main test that conducted right now. So it's conducted at the beginning. So when you have suspect TB patient, they usually have to check the sputum test, and from the sputum test using the rapid, I forget the name, the rapid test, we will see whether they are potentially resistant to rifampicin or not. So that's the I think that's has been conducted now at the primary health care in Indonesia, including in Bali, but not all have the test. So for instance, you will be tested in this primary health care, but you can the test can be referred to another, but it's still in close proximity. So I think that's a good start to start with. And regarding the resistance for TB patient, actually it is also related to the compliance, right? So it's a bit different from other diseases that TB need a long-term treatment, and this really also associated with the compliance of the patient, like taking the drugs, both in the intensive phase and then the second phase of the treatment. Yeah.
Thank you, Dr. Ayu. Now we know, so there is some capacity building happen already on the ground. So hopefully it can be scaled up. So that would be able to mitigate the spread of the TB resistant. Yeah. We have still 10 more minutes also. So if anyone have any questions, so feel free to ask that directly to Matt or Rachel. Any other questions? Okay, we've got one here.
Good afternoon, Dr. Matt and Ms. Rachel. I wanted to ask this question is for Ms. Rachel. How do you address the balance between the need to transfer patients for medical reasons and the potential risk from them getting the infection? Thank you.
That's a really good question. Thank you for your question. And it's one which the hospital clinicians fed back was super important to them, especially now where COVID is perhaps decreasingly a priority for them. Providing them with advice that they should reduce transfers or moving people to avoid COVID transmission probably is going to rank quite low in their risk matrix, and instead they'll say the main risk is that someone doesn't have a bed, so they need to be moved. So it's kind of recognizing that epidemiological advice and advice about outbreaks is always going to be within the broader context of the hospital operation and patient flow. And that being said, I think there's often a bit of wiggle room. So at face value, when we provided the advice that it might be helpful to minimize patient movement, there was immediately the response that that wouldn't be possible and that everything is already done to provide or minimize patient movement. But then I think if there's minimal changes that you can make that are quite easy, that don't impact the clinical experience or the patient care, you can make small gains against preventing transmission. So in the study that I spoke to, we had heard how patient movement was unavoidable, but there was ways in which they could reduce it slightly. So sometimes people were being moved for non-clinical reasons, and perhaps it was because the care provider didn't necessarily think about the risk of COVID or infectious disease transmission. It was kind of like a quick judgment. If you remind people, I suppose, of that being something to consider, and if it is a possibility that even one transfer can be reduced, so moving someone 2 times rather than 3 times, then I think that in the busy hospital complex environment can still help contribute something to reducing the spread of infections. But I recognize your point that it has to be taken in moderation with other things.
Yeah, and from your presentation, Rachel, at the end, you provided us with that table and you highlighted the reason for transfer. And that's, even with that, actually still a problem. So that's often not being completed by the clinician. And the system actually already there to provide some justification or risk of the transfer, but the practice, it's still, yeah, there is some issue with the practice. I don't know, so maybe Matt and Rachel can comment on this. So what actually, we've got the system, but nobody really follow the system, and yeah, so I don't know. Do you have any comment on that?
That's a really good point. I think you always have to come from the viewpoint that the care provider has the patient's best interests at heart. So they would probably know that a non-clinical move isn't the best port of call. But the reason that they're doing so is because they're under a lot of pressure from other members of staff. It's busy, they don't have time to fill in paperwork. So it's all, I think, about kind of, you need to look to the kind of systems level then, make sure that there's adequate funding, people feel well-staffed, well-resourced, so that they have the space and time to meet the regulations or the things that is asked of them. Because otherwise you just will see people kind of skipping a few steps because they physically can't meet all the requirements of them in that setting.
Okay, thank you, Rachel. So yeah, it's a lot of issue, and I think it's very similar in Indonesia. There is a lot of the guidelines, the procedures are very comprehensive, but in reality, it's hard to follow all of that steps, and it's not just in the hospital setting, but also a lot of issues in primary care setting. So we face very similar issue in that regard. Okay, we still have time. So if anyone would like to ask more questions, it's a very rare opportunity to be, yeah, so yeah, I would say it's a very rare opportunity to be able to have this conversation with Matthew and Rachel at the same time. So please use this opportunity. Any questions? Maybe from our colleague from NTB, from Lombok, yeah, why not? So Dr. Farah or Dr. Nurul, if you have any questions or you share some of your experience from Lombok. Sorry to put you on the spot. We've got Nurul and then we've got one more here. Yeah.
In Indonesia aja ya. Iya. Oke. Kalau di level puskesmas yang kami dengar, ini kami tadi juga sempat diskusi di belakang. Di level puskesmas teman-teman yang programmer TB ini mengeluh target untuk active case finding-nya itu terlalu tinggi. Karena mungkin memang didasarkan pada estimasi ya. Apa enggak memungkinkan gitu? Kan kita udah teknologi ya, udah digitalize semua sudah, sistem informasi juga sudah digitalize. Apa enggak memungkinkan kalau udah ada data by name by address gitu, jadi udah nggak proyeksi lagi gitu. KIA aja bisa gitu, ibu hamilnya by name by address, kok TB itu nggak diarahkan ke sana. Barangkali itu sih karena keluhan dari teman-teman target terlalu tinggi, atau mungkin kalau masih memang mau pakai estimasi itu mungkin estimasinya ditentukan mungkin per kabupaten, per kota, nggak nasional gitu. Barangkali itu sih beberapa masukan dari kami yang bisa ini. Ya, thank you.
It's a really good point, and I think it's a problem across Indonesia, Matt. So it's about the target for the active case finding, which is using estimation data can be often overestimate. So the target is too high. And a lot of the TB programmer at the community health center argue that the target is too high. And then what do you think about the possibility of using actual data by address by name? So that's the question. Maybe later on, Dr. Sawitri maybe can comment as well on this issue. Yeah. Yeah, or Dr. Ayu can also comment on this issue later on.
Can you just repeat the last bit of the question? I heard the
So,
first one.
yes,
the active case finding target is too
high, and then
using...
because at the moment what they use is the estimation data, so they estimate the target for the active case finding. What do you think about possibility of using the actual cases, suspected cases by address by name?
I think some have read some TB studies recently where they're using sort of that network analysis or something to identify ways that TB could actually be moving through the community to make targeted active case finding, but much more targeted. I mean, I'm not sure exactly what is going on, how they are deciding the targets in your setting. But I think any effort you can make to make it more targeted and appropriate to the situation where you're going to be using the resources most appropriately and efficiently, I think would make sense. But I don't think I can really comment on the detail there without knowing how the targets are now decided. So.
Thank you, Matt. Dr. Ayu atau Dr. Sawitri mungkin bisa ikut diskusi.
Ya, mungkin sedikit saya mengomentari terkait dengan penggunaan data estimasi gitu. Jadi memang kalau untuk yang sudah real ya, jadi kayak ibu hamil itu kan nyata sekali untuk dilihat. Jadi mungkin orang menyembunyikan kehamilan itu hanya bisa sampai bulan ketiga kali ya, bulan keempat pasti sudah kelihatan perutnya bengkak gitu kan ya, sehingga lebih mudah untuk dihitung. Jadi ketika kita menghitung berapa jumlah ibu hamil gitu ya untuk kita memproyeksikan ke depan, itu adalah didasarkan dari hasil sensus ya atau hasil survei yang memang di komunitas gitu kan, di komunitas jadi ketemu di komunitas misalnya 3%, nah itu yang digunakan untuk memprediksi di tahun berikutnya itu kurang lebih sekian. Jadi itu akan lebih akurat. Tapi ini kan berbeda dengan TB gitu ya. Jadi kalau dari perjalanan alamiah TB kan banyak yang asimptomatis, banyak yang mungkin mild infection gitu. Sehingga ini juga termasuk yang harus diestimasikan gitu ya. Jadi memang kita tidak mungkin misalnya kita melakukan survei nggak tahu mungkin Riskes tahun berapa ini ya bisa memeriksa langsung ya, kemudian menemukan berapa prevalensinya. Itu akan sulit gitu ya, makanya masih dia melakukan estimasi gitu ya, melakukan estimasi sehingga kalau dibilang jumlahnya itu targetnya terlalu tinggi gitu ya. Nah, itu mungkin juga tidak tepat gitu ya, tidak tepat ya. Mungkin yang benar itu mungkin karena memang tidak ketemu gitu, tidak ketemu karena sulitnya mencari di lapangan, masih banyak masalah. Dari yang asimptomatik dia jelas tidak akan datang, dari yang sudah ketemu pun mungkin pemeriksaannya juga lebih susah gitu ya. Saya masih percaya bahwa estimasi yang dihitung untuk TB itu masih cukup akurat ya. Nah, cuma permasalahannya adalah memang betul tadi estimasinya itu adalah di tingkat nasional. Jadi apa yang ditemukan di tingkat nasional gitu ya, mungkin kalau kita bawa ke level provinsi ataupun ke level kabupaten, mungkin itu yang membuat menjadi tidak tepat karena melakukan estimasi itu sangat sulit sebenarnya, apalagi untuk level kabupaten ataupun ini kalau ini tingkat puskesmas itu akan sangat sulit karena data yang tersedia mungkin tidak cukup untuk itu. Ya, mungkin itu sedikit dari saya. Terima kasih.
Terima kasih Dr. Sawitri. So essentially, Matt, so with and Rachel, so with TB is a little bit different compared to pregnant women. So pregnant women, we can use the actual prevalence this year, for example, to predict the number of pregnant women the following year, because we know exactly, oh, that's a pregnant woman. But for TB, it's a bit more complicated because there is some fraction of the TB patient might be asymptomatic, but also might have a mild infection. But according to Dr. Sawitri, the problem might not be the estimation, but the way to find the cases, because there are a lot of asymptomatic and mild infection. They're probably not aware that they might have the condition. And the other things that was mentioned by Dr. Sawitri, at the moment, the estimation conducted at the national level. So there are a lot of contexts not being considered when they estimate the number of target for active case finding at the district level, as well as up to community health center level. So the data can be a bit misleading because the estimation conducted at the national level. So so Dr. Ayu, do you want to add anything?
Yeah, jadi I think this is still issues that's always been mentioned by colleagues at primary healthcare level, because the target is also evaluated as their performance, right? When actually then when the target set at this number and they can't, I think the case finding in most of the district primary healthcare level is quite low, maybe around 40%. So it's below like the target to be able to find certain number of people. So that's actually the argument that the target is too high for them. Yeah, I'm not sure how it's calculated. I think it's still based on if they find certain incident in this year, and then also included the number of population in that particular area. So that's some of the number that has been used to estimate it, but I am not sure how it's calculated. But I think, I don't know, maybe it's also open for discussion. They need to have a better calculation as well. Because I don't know how it's calculated right now, but I think that's also open up for discussion. Because they estimating if there's a certain number of TB case active case already defined, and then certain proportion in the population, something like that, already also will have TB based on the transmission rate and everything. So, but I think although right now we can use that and agree it should be tailored to the local setting based on the local number, but it's open up for discussion to have a better estimate thing, because like right now I think that's from all the
performance indicators of the TB, the one is really high, really difficult to be achieved is the detection rate quite low in most of the primary healthcare setting. Yeah.
Yeah, go ahead, Dr. Savitri.
Iya, mungkin sedikit menambahkan, jadi belajar dari pengalaman di HIV yang sebenarnya, ketika kita melakukan estimasi untuk tingkat nasional, data yang kita gunakan itu adalah berasal dari data kabupaten, gitu ya, data kabupaten 514 kabupaten itu kita gunakan untuk nasional. Tapi ketika kemudian kita mendapatkan data estimasi di tingkat nasional, itu bukan berarti kemudian angkanya itu bisa kita bagikan ke kabupaten. Dari kabupaten kemudian kita bagikan lagi ke kecamatan dan puskesmas. Bukan seperti itu gitu. Jadi saya yakin pasti sudah dikalkulasi gitu ya. Tetapi dari pengalaman di HIV kemarin gitu, akan lebih baik kalau dari tingkat daerah, misalnya di kecamatan itu dia bisa melakukan estimasi berdasarkan data yang ada di kabupaten atau kecamatan itu, gitu. Itu akan lebih baik gitu. Jadi sebenarnya ini merupakan peluang sebenarnya untuk melakukan studi gitu ya. Jadi melakukan estimasi di tingkat yang lebih kecil gitu. Masing-masing kabupaten melakukan, masing-masing kecamatan melakukan gitu. Itu akan baik ya, dan itu sudah di HIV itu sudah kita dorong agar kabupaten itu mau melakukan, tapi sampai sekarang mereka belum gitu ya, tapi sama mengeluh juga targetnya terlalu tinggi.
Thank you, Dr. Savitri. So yeah, another comment. So at the moment, the national estimation, they did use district-based data, but then they distribute the numbers across the district, and then that lead to maybe too high for some district, but maybe not too high for the others. The recommendation was that so that each district or each sub-district, they should be able to do their own estimation. So that way they will get a more accurate estimation on what actually happening in their jurisdiction. So, but it's a long way to go because HIV, in the case of HIV, it has been advocated for maybe more than 10 years now, Doc? Yeah, more than 10 years. Yeah, or 20 years even. So still district level can't do their own estimation. So it's going to be a big exercise for Indonesia moving forward. Okay, we stopped the discussion around estimation. So we know that there is a problem with the estimation data. So, but there is also opportunity moving forward for us in the future to promote or even to provide the authority with this kind of assistance to help them in their estimation. We've got one more hand here. Yep, please go ahead.
Okay, good afternoon. Let me introduce myself again. My name is Bintang from Bachelor of Public Health. So I wanted to ask Ms. Rachel, if I hope I get this right. So back then in your presentation, if I remember correctly, so the solution to the outbreak in hospital from words to words was to have like a form when you want to move the patient. But if I remember correctly, it was not filled rightfully and not clinically right. So, okay, so my question is, do you think there is any other way besides a form to minimize the outbreak when you want to move patient from words to words? Thank you.
Thank you for your question. Again, really good point. Yes, other than a paper form, we considered a few other solutions or recommendations. One of them, rather than a paper form, was that the hospitals were moving to electronic records. And so it might be easier for them, rather than having to take the time to manually fill in a form, they would have a drop down and you would select clinical, non-clinical or other. And even having to say non-clinical reason for the clinician might prompt them like a small little nudge
just to reconsider, and that would reduce the time having it as an electronic form and make it more feasible for them to fill in. An alternative thing we considered was to improve handover of information when the patient was being moved between wards. So even if the person transferring the patient couldn't fill in either a paper or electronic form, they could have a verbal handover with the member of staff who was receiving that patient and say where they had come from. So if they were deemed to have come from a high risk ward, something like a COVID ward, or they had been a contact of a COVID case, that would be flagged to the receiving team. So they would be aware of the potentially high risk nature of that person. There were some instances where people were being moved and the receiving team hadn't any idea that they had previously been a COVID contact. And then that person was put in a bed next to someone who was quite vulnerable, and that then seeded an outbreak. So even if that verbal handover of information could be improved, that was another option we provided.
Yeah, it's very practical. Yeah. So, right. So we actually run over time 15 minutes. So with the band, the band actually settled down. So good that we can have a really nice discussion. So once again, thank you very much, Matthew and Rachel. So it was really insightful, and really, I'm hoping that the information useful for the master student and the bachelor, but also faculty members. Hopefully, in the future we can come up with some research ideas, and then. But Matt, hopefully, we will. We just need the money to do the study. So I'd like to invite all of you to give a round of applause to both of the guest speakers. And thank you. So I would like to hand it over back to Dr. Ayu. Yeah, thank you.
Yeah, just please stay there because we're gonna take picture after this. Thank you so much, Dr. Sutarsa, for moderating the session. Thank you, Matt, and thank you, Rachel. I think it's really great discussion and also sharing, and the good thing that Matthew and Rachel also provided a lot of different question or research question that can be answered ya in small scale. Nanti adik-adik bisa beberapa aspek bisa diteliti. Ini ke depan kan mau nggak mau harus meneliti ya, baik yang sarjana maupun yang master kan akan melakukan penelitian. Jadi banyak ide-ide yang bisa dilihat dari tadi ya. Mungkin banyak yang tidak tahu, oh TB itu ternyata seperti ini, sekarang DM begini, dan ada TB DM comorbidity. Jadi ada aspek yang mungkin membuka wawasan kalian ya, sehingga lebih banyak melihat dan membaca, melihat situasi. So we are also expecting the 2023 national research data, which is really exciting. Actually, we want to see what is changing, whether that's getting worse or getting better. It's also reflecting how the program works. So it's a lot of question regarding the epidemiology aspect, mapping like the one that Matthew conducted, and also question regarding the program evaluation itself. So that's a huge question and that can be asked. And actually also Rachel sharing today will, I think, open up also opportunity, because usually public health student and also public health staff is just focusing on something that happening in primary health care setting and also at the community setting. We rarely do research on the hospital setting, although maybe our colleagues at the specialty program doing it, but not from the public health perspective, like the epidemiology perspective. I think that's also another opportunity. Maybe some of the students will have their internship or PKL in hospital, so that kind of question can be also asked and studied. Yeah, jadi I think from today's lecture we have a lot of burning question issues to make us more read more, explore more gitu ya adik-adik ya. Jadi semangat buat kita semua. Terima kasih banyak. Thank you so much for today's sharing. It's really been grateful and beneficial for all of us and also me, myself. And yeah, before we close the session, we have some souvenirs for Matt and Rachel. Dr. Sawitri will be presenting the small souvenir from us. So hopefully you will like it. This is, I think, Balinese hand-woven fabric. Yeah, so we can keep the memory of the event. Okay. Ayo ada bangun. Jauh banget. Ayo naik kan? Bisa kan? Mendekat merapat ke dalam. Sana aja. Ya, terima kasih banyak ya adik-adik semua. Jangan lupa nanti minggu depan kita akan ada another guest lecture tentang mental health. Jadi nanti boleh yang sekarang hadir atau mau di rolling, banyak perspektif yang berbeda yang bisa didapatkan ya, sekalian belajar juga mendengarkan dalam bahasa Inggris. Jadi mudah-mudahan bisa belajar. Terima kasih banyak semuanya.